So, Sheri, while Carl joins us again, let's maybe begin. So, who exactly are you?
That's a good question. So my name is Sheri Fanaroff. I am a family physician or general practitioner in Melrose, Johannesburg. I have quite a small practice by design. I like it small because I like to be able to give my patients enough time and attention, and also because I am also a mom and a wife, and I have a bit of family life, so I don't really want my practice to be bigger than it is. I've been quite active through the COVID pandemic because I really strongly believe that it's important to get information out there. We're fighting, besides the COVID virus, a massive misinformation pandemic. And I really think that people have been desperate for information and accurate information. So I've tried to play my part by sending out regular messages on whatever's current. You know, I generally send out something. I'm not as good as I was with every twice a week or every week, but every couple of weeks generally. And essentially I answer the questions that I've been most asked in the preceding weeks. And I get lots and lots of questions about COVID.
So, Sheri, you've also got a master's in family medicine. And,
I do.
And no question is out of bounds. So now that we know who you are, Carl, do you want to tell Sheri quickly who the SciComm and IATL family is?
Sure. So I'm sorry for all my technical difficulties, but I eventually, Howie, it's exactly what you would say if we asked you to use WebEx. I just don't use Zoom enough to know what the hell I'm doing. So, but I made it here. But Sheri, firstly, thank you very much for your time. I think, we're a business of about 70 people across, I think, IATL, maybe a little bit more, IATL and SciComm, and we're a telecommunications company. So we, from a COVID perspective, have been an essential services provider from the beginning. So haven't really had a day off, and I think from an installations perspective, our guys have been in the front line and have been facing COVID head on. But I think we are a pretty I would say futuristic business in that we adapted to lockdown really, really well. We were online very, very quickly. But I think we are, just like everyone else, very, very keen to understand vaccines, very keen to, make sure that the misinformation that's out there is not tainting our decisions. So, we're just looking for a little bit of clarity. And I think I speak on behalf of our entire business that, most people want to be vaccinated, whether they agree with it or not. But I think the more questions they can answer, the better. And I think this is just about, giving us information, allowing us to absorb it, and I think helping us making the right decision.
Okay, so I'm going to try my best. Howie emailed me about 2 hours ago a long list of questions. And to be honest, I have literally skimmed through them. So
Sheri, maybe let's start just with COVID generally. So if you look at how many people have died in South Africa since COVID began, there are two sets of numbers you can look at. The official government numbers, which show about 75,000 people, but there's also something called the excess deaths, that you look at how many people have died in the last 16 months over and above the number that we would have expected that the actuaries predict. And that's the number that people like Discovery Health look at. And that's sitting at close to 230,000 people. More people have died in the last 16 months than would if we hadn't had COVID. I mean, that's obviously an issue of concern, like 230,000 dead people, more than you expect, should be something we panic about.
So absolutely, it's a huge amount. And, that kind of it makes me think of the biggest misinformation about COVID in that it's just another flu. Flu annually causes 6,000 to 12,000 deaths maximum. And if you look at the amount of deaths that COVID has caused in 1 year, it is like, my maths isn't very good, but 10 or 20 times the number of deaths that the worst flus have ever caused. So and that is reported deaths, not even looking at your excess deaths.
So Sheri, you've had a lot of patients with COVID. I mean, I presume, despite some of the best medical care, a chunk of them have died. What are the symptoms? How do people just go through again, especially with the new Delta variant? What are the symptoms that people should know? Because I still keep on hearing, particularly from people in Cape Town, that, oh no, they've got sinus or they've got flu and it's okay. And then someone forces them to go get tested and it turns out that it's actually COVID.
So unfortunately, that's quite common. I can't tell you the number of patients who come sit in front of me because they've kind of gone through our screening mechanisms and told me it's definitely my allergies. It's the sinus I get every year. And with Delta variant, one of the common early symptoms is a blocked nose, sinus congestion, and a sore throat. And certainly in the time of a pandemic, if you have those symptoms, it does warrant a test. Other early symptoms are headache, body pain, fever can be one, loss of taste and smell we're still seeing, but much less so with Delta than with the Beta variant. It was much more prevalent earlier in the pandemic. And then obviously cough and shortness of breath. But actually, if you have any of those symptoms that you don't usually have, it probably warrants a test or at least a phone call to your doctor to check if you should have a test.
Now, Sheri, a lot of our colleagues, Carl is like the grandfather in the business, but a lot of our colleagues are much younger. And traditionally, certainly when COVID began, youngsters didn't really worry about it. They weren't necessarily at risk. Has anything changed with the Delta variant?
We are definitely seeing younger people, and a big age group actually that are affected are men in particular in their 40s and 50s who've been very severely sick. Obviously others, not just, but for me, that age group stands out. And when I have a patient who's in that age group and not vaccinated, I panic because I've had a few patients in that age group who've done terribly. I've got a couple of young men, one of whom is a triathlete and now dependent on oxygen, and it's devastating. So we're seeing younger people, many more kids also involved in this Delta strain. In the third wave, we're seeing a lot more younger children, teenagers, and certainly more young adults. And that maybe also speaks to the fact that our 60, 65 and older in this pandemic had already had some protection from one vaccine, that we're seeing it now shift to the younger generation.
I mean, we're also seeing younger people die. I mean, someone who lived in Carl's building, who I was friendly with Carl and I, 37, dead a few weeks ago. No one is spared at this point.
So you can't assume that because you are previously young and healthy, that you're definitely going to have a mild disease. The truth is that you are less likely to have severe illness than somebody who's much older. But I've had 80-year-olds who've sailed through it with mild disease, and I've had 30-year-olds who's sick. At the moment, I've got a 15-year-old who's really, really ill, kind of making a decision whether or not to admit her. And she's 15 with no prior abnormalities. So you can't make the assumption that because you're young and healthy, you won't get it severely. There are lots of factors, and I wish we knew the factors that make somebody more vulnerable than somebody else. And maybe in 5 years or 10 years' time, we'll know for sure what those underlying factors are. Are they genetic? Are they, blood group related? There's some things looking at that. But the truth is now we don't know who's more at risk of getting severe illness.
So, Sheri, it's a new disease. It's been around in the world for under 2 years. And we're learning a lot about it. And we're also learning a lot about how to prevent it. In the beginning, I seem to remember you told us we mustn't use masks. And then we understood how it was transmitted. And then masks became crucial, and hand sanitizer and social distance. We've learned all of that. But I think now that we're in the era of the vaccine, tell us a little about vaccines generally, and then let's start addressing this issue was this a rushed vaccine? Should we be worried about the vaccine itself?
So the concept of a vaccine generally goes back, way before any of us on this meeting were born. And the concept of a vaccine is to introduce your body to an illness in a small protected way, and so that your body can mount a defense against that illness should it encounter it. So if you look at probably the best viral vaccine success story, and you look at something like smallpox, smallpox was completely eradicated by vaccines. It used to cause death and severe illness. It doesn't exist anymore because the population got to a point where enough people were vaccinated that the virus died out. Polio is much the same. Even a virus like measles, which we do sometimes see breakthroughs, particularly in unvaccinated populations. Measles used to cause hundreds of thousands of children to die around the world. Every now and again, you hear about an outbreak of measles, and measles can be severe and serious. But in general, vaccines have completely brought an illness like measles under control. If you look at something like influenza, a lot of you probably remember when swine flu was a new illness, a novel virus in 2010. People were really ill. A lot of people were hospitalized with swine flu then. And that was because it was a new mutation to the existing flu vaccine. They managed to change the vaccine. There's now a strain that vaccinates against swine flu. And we don't see severe cases of swine flu anymore in a vaccinated population. And thus, even in some of the unvaccinated population, because there's much less viral load. So does that answer your question of the history of vaccines?
It does, and we all vaccinated. I mean, I presume I got measles, mumps, and rubella when I was a kid. I got smallpox. I'm talking about vaccine, not obviously smallpox. Mm-hmm. I got polio, and I travel incessantly, and you're my GP, so I continuously come back for a hepatitis injection, particularly going into Asia. And some of those vaccines you don't only give once. Like hepatitis, you give 2 or 3 times, if I remember correctly.
So most vaccines require boosters. In fact, almost all. If you look at the childhood regime, children get vaccinated against most things, like including the common diphtheria, tetanus, whooping cough, which are the kind of 3 main ones. They get it at 6 weeks, at 10 weeks, at 14 weeks. They then get it again at 18 months. They get another booster at 6 years, and they get another one at 12 years. And then you may need a tetanus booster, every 10 years throughout your adult life. So the concept of boosting for vaccines is not new. The concept of having a vaccine to allow you to travel, even, how you brought that up, is also not new. There are countries that require a certificate for yellow fever to show that you've been vaccinated against yellow fever. TB is another one. It's very much a South African illness. I often have students who go off to study in the US. They have to prove that they've had a TB vaccination, or they're not allowed into the university. And in fact, a lot of vaccines, the US are very good at asking for vaccine documentation. Our universities here are not so good, unfortunately, at asking for it. And we sometimes see outbreaks of meningitis or chickenpox, mainly in an unvaccinated population.
So when it's come to COVID, there were probably 30, 40 horses in the race to see who would be able to create a successful vaccine. And people took different paths. There were some people that went for something called a messenger RNA vaccine. There were some people who went for an adenovirus, an attenuated virus. Can you kind of run us through what is the different ways to achieve basically the same result?
So the essential part of a vaccine is that you want it to have something that causes the body to recognize and mount an immune response. So let's talk about the 2 in South Africa. So the Pfizer vaccine is an mRNA or messenger RNA vaccine. And what that does is that it causes the body to, the mRNA gets into the cells, and it causes the body to produce a piece of virus from the spike protein, or that looks like the spike protein. And your body then makes antibodies against that. And besides antibodies, all the white cells, T cells and B cells, are kind of alerted to the fact that there was a foreign body, and they are kind of primed. And then should they come into contact with that again, they can rush to that site of the virus, and you create a good immune response so that you don't have a virus that overwhelms your body, because the virus is kind of killed off quickly because it's recognized by your immune system. The J&J vaccine uses an adenovirus vector. So an adenovirus is it's a killed, it's an inactivated virus that kind of carries a piece of the spike protein into the system, and that helps your body to make the protein. So adenovirus has been used in Zika vaccines, it's used in Ebola vaccines, and a lot of HIV vaccine trials were also done using adenovirus. Unfortunately, we still don't have an HIV vaccine. And then mRNA also, it's not a new concept. mRNA has been used in lots and lots of different studies. The SARS-CoV-1 infection, I think, was identified in around about 2000. And even then, back in 2000, they started to investigate making a vaccine against SARS-CoV-1 using mRNA. So actually the mRNA technology is around 20 years old. So when COVID arrived, and now it wasn't a problem of the East, like SARS-CoV-1, and it wasn't a problem of Africa, like HIV. Suddenly it was affecting rich countries, America, the UK, Israel, and the whole world, essentially. Scientists from all over the world collaborated, and there was a massive race and enormous funds put into developing vaccines that were going to save the Western rich world, because suddenly they cared. And I think that the amount of resources and brains and time put into it in the 1 year that it took to bring a vaccine to the market is probably equivalent to 20 years of money, research, brains, and time that have gone into a lot of the other vaccines. That's kind of the way that I see it.
So I just want to get clarity on two things that you answered. The one is, does the vaccine actually give you a mild form of COVID or not? That's question number one. And question number two is, does the vaccine prevent you getting COVID, or does it just help you fight COVID if you get it?
Okay, so your first question, there's no possible way that the vaccine can give you COVID. You've got to get COVID, you need the actual DNA of a live virus. So it's not possible for a vaccine to give you COVID. And the second question is that it may not, in fact, it will not completely prevent you from getting COVID. If somebody sneezes on you and their mucus goes into your mouth and you inhale a high viral load of somebody's saliva or snot or whatever that's got COVID in it, you probably will get a form of COVID, but because your body's been primed and you've had a vaccine, the immune system will jump on that virus and neutralize it very quickly so that it shouldn't cause a severe form of illness in your body. It shouldn't replicate it. You shouldn't be able to make like a big viral response because your immune system's on top of it the minute it recognizes it.
So now one of the concerns that we hear from people, particularly with messenger RNA viruses, will it go and change my DNA in my body? Will somehow something get affected? Will I be a different person? Will my DNA be changed as a result? What's the answer?
That question fascinates me because mRNA viruses can't get into the nucleus of a cell. So from high school biology, you learn that DNA is only found in the nucleus of the cell. The mRNA cannot get in there, nor can the adenovirus. There's no feasible way. It's a sci-fi concept. It's a ridiculous concept. I don't even know how to answer it. It cannot do that. If somebody could invent something that would change your DNA, I think we are still hundreds and thousands of years away from that. mRNA viruses can't do it.
So, Sheri, the other thing that people have concerns about, for example, is they're trying to fall pregnant and they worried about, will this affect their pregnancy? Will this affect their sperm count? Will this affect their feeding of children? Fertility and lactation. Is there any effect that the vaccines have on any of those elements?
So it is a question that's asked a lot. And unfortunately, it's one of the things that anti-vaxxers really kind of prey on, because there's a big concern, obviously, and particularly in young people, that you have something now at the age of 20, what's going to happen at the age of 30 or 35 if you decide you want to have a baby? So, and then the other issue with that, why there's a lot of concern, is that the initial vaccine trials obviously don't use pregnant women and lactating women, because those are a protected population. So the initial trials left those out. But what we do know about vaccines is that none of them are live virus vaccines. None of them, not one of them, have been shown to affect fertility in any way. And in fact, there are hundreds of thousands of women who've already fallen pregnant having had a vaccine, and even delivered babies having had a vaccine. So there's so much info I could give you. What's very reassuring is that the South African Obstetrics and Gynecology of South Africa, South African Obs and Gynae College of South Africa, actually this week came out with a statement encouraging all women of reproductive age to get vaccinated. In pregnancy, the risk of having COVID itself is actually dangerous both to the mom and to the newborn. And there are a lot of studies that are looking at COVID in pregnancy having a high incidence of premature births and also of some stillbirths. Lots of reports of maternal deaths also. And it is definitely recommended at this stage that having a vaccine in pregnancy is a much lower risk than having COVID in pregnancy.
What about for men, for things like sperm count?
So I was coming to the fertility. So in females, just to start with that, there's absolutely no evidence and no reason to believe that it can affect fertility. And a lot of the big gynae organizations published in the British Medical Journal, for example, that there's no effect on female fertility. In terms of men, there was a recent study published in Journal of American Medical Association, which is a really respectable journal. And this is the very first one, it was only a couple of weeks ago, that actually took sperm samples from men before they had an mRNA vaccine. And then they got sperm samples from the same group of men 70 days after their second vaccine. And there was absolutely no difference in the semen volume, in sperm count, in sperm motility. So that pretty much throws that out of the water. And in fact, COVID itself, again, and this is what we keep coming back to, is the vaccine safe or is COVID safer? COVID itself has been shown to cause men to suffer from things like erectile dysfunction because of vascular problems, because of lung and breathing and heart problems. And also recently they've done some biopsies on testes, post-mortems of men who've died, and they have actually found COVID virus infection in the testes and affecting sperm counts there. So having a vaccine actually is likely to preserve both your erectile function and your fertility, not the other way around.
What about lactating mothers?
So again, that's actually a really safe group to have a vaccine. It's advantageous to the baby because the mom's going to make antibodies, and antibodies have actually been found in breast milk. So there's absolutely no harm to the baby, and in fact benefit because the baby's getting antibodies.
So people go for their vaccine and some of them get side effects. I mean, is that a bad thing, or is that your body actually showing you that it's working? And what side effects could you get from the vaccine?
So exactly, you've answered for me. The side effects that we commonly see from both the J&J and the Pfizer are fevers, headaches. The very commonest one is pain at the injection site, muscle aches and pains, and that's actually a sign of your body mounting an immune response. So it's actually a good thing. Sometimes people phone me and say, I had my vaccine and I had absolutely no side effects. I think I didn't get it. And it doesn't mean they didn't get the vaccine. People are different. Our bodies are all different. People also have a different kind of pain threshold. So my arm's always really sore after a flu vaccine. My husband always tells me he didn't feel a thing. I'm just a baby, I'm moaning. So, people's perceptions of reactions are also different. What's interesting, actually, in studies that looked at mild side effects from the vaccine, showed that younger people complained much more about the mild side effects than older people. And I found that quite interesting because assumably the side effects are similar. It's just the perception of them.
So once you've gone for your vaccine, and let's deal separately with Johnson & Johnson and Pfizer, because one's one shot and one's two shot. So let's start. If you had a choice between the two, are they the same thing, or do you go for whatever's in front of you?
So a few weeks ago, I was answering that question with the best vaccine is the one that you can get first because you need a vaccine in your arm. I think if you're at a site and both of them are available, that it's quite an individual decision. The J&J, the advantage of it is that it is one vaccine. You will have good immunity from 4 weeks after being vaccinated. And in fact, you'll even have some immunity from around 2 weeks after being vaccinated. So that's quite quick. So, if you have to travel somewhere and you need protection, or if you're somebody who lives far from a vaccine site, or if you just don't have time to go and stand in a line, perhaps to get the second dose, then the J&J is it's a good choice there. The data that have come out recently looking at the efficacy of the J&J vaccine and the safety, and they were published by Glenda Gray about 10 days ago, and her 8-month data, which is as far as they've got in terms of efficacy, are excellent. It's still providing 95% protection against death and about a 90% protection against hospitalization. And that's a phenomenal result. It's a lot more than the flu vaccine. Flu vaccine gives us about a 50% reduction in severity of illness. And then the Pfizer vaccine, why would you choose that? Pfizer, to me, is probably the Ferrari of vaccines. It's been used probably most. The results are excellent. And it's a vaccine that is most probably going to allow you to travel to anywhere you want to go. So, if you are looking at getting into Israel, the US, the UK, a lot of those countries have still stipulated that they will only accept a Pfizer. So, you have to kind of look at where you're going. The disadvantage of the Pfizer is that it takes longer to get your full immunity. So you have your first shot. You've got some immunity around 3 weeks after your first shot. You've got to then wait until your second shot, which is 6 weeks after your first one. And then only 2 weeks after your second shot do we say that you've got full immunity from Pfizer.
So in fact, South Africa extended the period from 3 weeks to 6 weeks between your first and second Pfizer shot. Is there a scientific reason for doing that?
Absolutely. So when the initial countries were doing it, they were giving a 3-week gap between the two doses. And then other countries waited longer, and the studies showed that the longer wait, somewhere between 6 and 8 weeks, is actually the ideal time in terms of waiting for immunity. And they think that if you've waited longer than the 3 weeks, so looking at 6 or 8 weeks, that the immunity is going to last a lot longer. So there's definitely an advantage to waiting. The results from the trials look better. So if you look at a country like Israel now, Israel did strictly 3 weeks afterwards Pfizer shots, and they are certainly finding that immunity 6 months down the line is starting to wane. And that's why they're looking at doing booster doses already now at 6 months in the older population. We are hoping that ours is going to last for longer. We don't know yet, and that's actually the advantage of being in the Southern Hemisphere and behind some of the other countries, because actually we'll have data quite soon, and we'll know at 6 months whether we need to start looking at boosters or not.
But we've seen, for example, in the United States, they've started looking at boosters. In the UK, they're talking about Johnson & Johnson boosters as well. But that's not unusual, because you told us earlier that many of the vaccines require boosters. I mean, you gave examples of one where it sounds like we needed like 6 in order to be fully vaccinated.
Yeah, that's absolutely right, because every time your body is exposed to the virus, it recognizes it quicker and it mounts a better immune response. And over time, that immunity might wane. So this is an example of where we're still learning. And that's why I say we're actually at an advantage here, because we're kind of trailing behind the other countries time-wise, we'll know the correct timing that you should have a booster. So the CDC did this week, they have approved boosters at 8 months for their Moderna and Pfizer vaccines. And that's because they're finding immunity is waning. And it's particularly because of the Delta strain, which is really contagious.
So, Sheri, we did one of these on the eve of Women's Day, and I posed a question to you together with the head of vaccines from NRCD, because I have a cousin in Cape Town who tells me that he knows that people who've died of the vaccine. And we posed this question we had yourself on the panel, we had the doctor in charge of vaccines from NRCD, we had a pulmonologist on the panel, a professor, and there seems to be no evidence that there's been a single case of anyone dying from vaccines in South Africa.
So there hasn't. And in fact, between that webinar and now, I think yesterday, in fact, SAHPRA published their kind of investigation data. They were investigating 56 deaths, which were reported soon after a COVID vaccine. They haven't been able to link one of those deaths with a vaccine. So what people don't always understand is that any kind of severe adverse reaction in the few months post-vaccine can get reported. So you can leave the vaccine site and get run over by a taxi and die. And that death is in fact linked because because you have registered for a vaccine, it's picked up, all the deaths are picked up because your ID number's there and you've got a death and they know you've had a vaccine. So that kind of thing, being run over by a car, is then linked and called a vaccine death. And that's the kind of thing that SAHPRA investigate. I mean, obviously that's an extreme example, but you know, many people, and particularly an elderly person, may have cancer and go for a vaccine and they might die 2 weeks later. They were going to die anyway. So the SAHPRA study, and you can go look at it online, was published yesterday, and not one of their 56 has been linked. I think they've got 4 that were uncertain due to lack of information. So we may still get clarity on those, but there is not one death linked to a vaccine in South Africa so far.
Now, another thing we hear is that we're being used as guinea pigs. This is a big experiment. We're part of guinea pigs. It's a very big experiment because there are about 2.5 billion people in the world who've received vaccines so far. What do you think about this concept that we're all involved in one big experiment here?
So it is an experiment, I agree with that, but you can choose to be in the group who gets vaccinated, or you can choose to be in the control group who don't get vaccinated, and you can take your chances on that. You know, the vaccine, people say, is experimental, it's not FDA approved. I'll come back to that. I understand the concerns of people who say we don't have 5-year data in terms of safety. And that's true. You know, we don't have 5-year data in terms of safety. But historically, if you look at vaccines and the way that vaccines are done, if you're going to see side effects, they are generally within the first very short while, probably 6 weeks. And if you look at the number of people around the world who've been vaccinated, and something like 4 billion vaccine doses have been given worldwide, whereas only millions of people have been infected with COVID. You know, it's one has to look at the fact that really the benefits are outweighing the risks. I understand people that are anxious. I can't say to you, I have 5-year safety data. It just, the way that vaccines work, we don't expect to see long-term side effects. And we know that COVID causes massive long-term side effects and death. And then you die from COVID. There's no long-term side effect of that.
One of the questions that was posed by someone was, will I be magnetic if I have the vaccine?
No.
Will
there's nothing magnetic in it.
Will I have a 5G chip implanted and will Bill Gates follow me around? which I hope he does, because maybe it's dishing out cash. Who knows?
I can't even answer that. I mean, the truth is Bill Gates probably follows you around on your cell phone anyway. So if your Bluetooth is turned on, he's probably checking you out right now.
But I mean, you've seen the vaccine. There's no chips in it.
There's nothing metallic in it. I've also seen the videos online where people have a vaccine and put metallic objects and it supposedly sticks to them. It's part of this massive misinformation campaign. It makes absolutely no sense. It's completely baffling to most doctors.
So let's talk about this issue of FDA approval. Of what approval has it gotten and why isn't there full approval yet?
So all the vaccines used worldwide at the moment only have FDA emergency use approval. And it's simply a matter of timing. So I think the first ones to get emergency approval were Pfizer and Moderna in December, and J&J, I think, only got emergency approval in February, and some of the others have followed. So if you look up what criteria something needs to get emergency use FDA approval, there first of all has to be, an acute need to use something. So the pandemic of COVID, we know, is causing massive numbers of deaths and illness around the world. So that then warrants something being looked at for emergency use. But to get approval, the vaccine still had to go through absolutely rigorous scientific processes. Stage 1 trials, which have a small amount of people, stage 2 trials, stage 3 trials, which have got hundreds of thousands of people. So in order to get full FDA approval, which I understand is quite imminent for some of them, it's a matter of looking at real world data as well as just clinical trial data. And it's just really on a bigger scale. So, that's where we are. A lot of people's, I think, vaccine hesitancy is fueled by the fact that there's a lot of kind of stuff online that says they don't even have FDA approval. Well, they do. The fact that they've got emergency use approval is just a factor of the timing. So I understand that the vaccines will have approval by the latest, will have full approval by the latest January, February 2022. And most sources are actually saying much sooner than that, within the next 2 months. So and then also SAHPRA, sorry, just to come back to that, SAHPRA is one of the strictest organizations worldwide in terms of granting approval to vaccines. So for stuff I don't know, the people who work at SAHPRA are like absolute bulldogs. They are absolute sticklers for the science. And the fact that SAHPRA approved both Pfizer and J&J quite quickly, whereas they've rejected lots of other meds, including the iron med, because of not enough data. You can be a conspiracy theorist and say they were paid more, whatever you want to say. It's simply, the simple fact is that they have absolutely rigorous processes before SAHPRA will approve.
So, Sheri, there were some reports of blood clots and things like that from the vaccines. Very, very uncommon. But let's actually address that issue.
So there are reports of blood clots, particularly with the J&J vaccine. There's an entity quite well described called TTS, which is a low platelet clotting disorder. And the fact that it's got low platelets makes it quite hard to treat. I don't have the figures at my fingertips. I can send them to you. I have them written somewhere. But the numbers are absolutely minute. The numbers per million people vaccinated are tiny, whereas COVID itself causes a massive risk of clotting. And that's what a lot of people who are in ICU struggle with, clotting from COVID. So if you look at the incidence of the tiny risk of clotting in a small percentage of people from the vaccine versus the massive risk of clotting if you get COVID, again, the benefit far outweighs the risk.
So Sean is asking the question. He says, how do I know if I get a vaccine that I'm getting the genuine vaccine and not a placebo? But just to tell everyone, there's a Q&A button at the bottom of your screen. You can ask any question and you can do it anonymously. So if there's anything of concern that you want addressed, please use the Q&A button at the bottom. Carl, you'll be monitoring that Q&A button. Please feel free to do anonymous as well. We want everything addressed. So just do whatever it takes. So Sheri, this idea of placebo and vaccines?
If you're having your vaccine at a reputable place, a pharmacy, a discovery site, a government site, you're not getting a placebo. I mean, you have to, I don't know how to tell you that, you know.
Because there was, right in the beginning when they were doing the initial trials, there was a control group and a non-controlled group, and some got placebos, but that's kind of 8-10 months ago.
Now, this is not a trial. So as I say, one has to trust in the system if you're at a reputable vaccine site. So in order to get a vaccinator's license, it's actually quite hard. And I know because I've done it. It's 18 hours of rigorous, excruciating information, most of which one doesn't need in order to put a jab in somebody's arm. And most nurses, doctors, whoever else are giving the vaccines have been doing injections for years and years, and we still have to do the 18 hours of training. At the sites themselves, the vaccines are actually, particularly the Pfizer, which is very temperature sensitive, there's a rigorous process by which they mix doses. There's something like 6 doses per vial, and they're mixed up and they only take out what they need. So, you know, you have to trust if you're going to a reputable site that you are getting a reputable vaccine. There are no placebos, so no, it's not a trial. It's the real thing.
So, Sheri, are there any people who shouldn't get a vaccine?
Very few, actually. If you are allergic to something called, I need to get the name now right, DEP, diethyl glucamate. Not sure if that's right, I have to check it. It's one of the vaccine ingredients. It's an extremely rare allergy. Then you shouldn't get a vaccine. So there are, you know, there are little pockets of people who are actually allergic to it. That substance is used in many other vaccines. So that type of person would have had a reaction to something previously. People who are on chemotherapy or who are immune suppressed, some of them may be able to get a vaccine, but some may not. They need to check that with their oncologist or with their rheumatologist. And then the vaccine hasn't been studied enough in people under 12. But, you know, other than that, there's almost no reason that completely excludes somebody from getting a vaccine.
So someone says, what about asthmatic patients? Can asthmatic patients get the vaccine?
Asthmatic patients absolutely should get a vaccine because they would be at higher risk of getting a complication, a lung complication from COVID. Asthma is a comorbidity. So anybody with comorbidities, asthma, diabetes, heart disease, those are the people who absolutely should be at the front of the queue to get vaccines.
And Vicky says if she, in fact, had a bad reaction to the flu injection and made her really ill, should she have any concerns about having the vaccine?
I think that's something that you should discuss with your doctor. They're very, you know, they're both vaccines, but they're different vaccines. There are lots of kind of reasons that somebody may have a reaction. Was it a reaction to the flu vaccine or was it something else? But in general, you know, if there is concern about previous reactions to vaccines or previous severe anaphylaxis, severe allergic reactions, so say somebody who's had anaphylaxis from a bee sting or from penicillin, those people can still get a vaccine, but there are 2 kind of caveats. The one is that I would suggest that they go to a vaccine site where they can be monitored properly and resuscitated, you know, if need be, because actually anaphylaxis, if it happens, is completely treatable, but you need adrenaline and you need kind of resus medication. So those kind of people should go to a hospital site, Moore Park Hospital or the Hatsola site or somewhere where there's people around who can help should you have an allergic reaction. And also people who've had prior allergies should wait at the site for 30 minutes so that they can be monitored. Anaphylaxis and allergies happen immediately. They don't happen beyond a 30-minute time period.
And if you've had COVID already, should you still go for a vaccine? How many vaccines? How long should you wait for?
If you've had COVID, the general guideline is that a vaccine will give you longer lasting immunity and probably better immunity, because we don't know, it's not controlled if you've had COVID, what kind of immune response you're going to mount. So there is some controversy on this and lots of push from groups like Panda, who've put out a lot of stuff about natural immunity is better. But at the moment, if you look at the evidence-based websites, they are still saying that vaccine immunity is better, particularly against variants and new variants, like Delta was a new variant, and new variants that might come, and it's going to last longer. So if you've had COVID, you should wait 30 days after recovery. If you've had mild COVID, to have a vaccine. If you've had severe COVID, so if you've been on oxygen or if you've been in hospital, you should wait about 90 days after recovery before you get a vaccine. And then how many doses should you have? Actually quite controversial. So in South Africa, the official guideline is still to do 2 doses of Pfizer. Some countries, Israel and the USA, have said if you've had COVID, that's kind of counted as your first dose, and the vaccine is your booster. So it's kind of controversial still. I think if somebody's had severe COVID, they can probably get away with 1 vaccine. My view is that if you've had mild COVID and waited your 30 days, I would still go and get a second vaccine. I think it's going to give you longer lasting immunity.
Marianne is asking about exercise. If you've had your vaccine, should you wait before you start exercising again?
So it's a good question, and there's actually no definite scientific answer, but the general guideline is not to do severe exercise for around 2 days afterwards. I've had lots of younger people who've had vaccines and have asked, can they do something? And I generally say to them, do a little bit, but don't go run a marathon, don't get your heart rate way up. Do a lower grade workout, which I don't think is harmful as long as your heart rate stays, at an okay rate. It shouldn't go up to your maximum heart rate for 2 or 3 days. And then if you exercise, as long as you're feeling fine, I don't think it's a problem.
So Sheri, I presume you've had a vaccine, and I presume your family's had a vaccine. I don't know, you'll tell me. And would you send your kids for a vaccine? So
I was looking, somebody said the vaccine queues are quite long today. If you saw at the end of February, when doctors could get a J&J vaccine, literally doctors were fighting each other because there were only certain numbers of doses, and we knew how important it was. And there were massive queues, thousands of people at Steve Biko and Barrow hospitals in those first weeks when doctors were initially able to access a vaccine as healthcare workers on the trial. And, that for me should be enough evidence to everyone. What do the doctors know who are treating the sick patients and watching them struggle to breathe and die? Why were we so desperate to get vaccines? And especially right at the beginning when we didn't really have a lot of data, especially about the J&J. And it's because we know that we understand the concept that vaccines were going to give us protection. So yes, I had a vaccine at the end of February. I had a J&J vaccine. My husband had a vaccine as soon as he was eligible also. My children are still teenagers. I've actually got a daughter who's 17 and only 18 at the end of December, and she's in matric. And I have to say, I'm plotting and trying my best to think of a way to get her a vaccine now, because she's not eligible at 17. And I would really love her to get vaccinated.
So if I've had a vaccine, what are my chances of landing up in hospital in comparison to someone who doesn't have the vaccine?
About 95% less. So I'm not a maths person, so I don't want to spout out
we worked out the other day, you have about 8 times greater chance of landing up in hospital and dying if you've had a vaccine as opposed to not having had a vaccine. So the unvaccinated unvaccinated people have an 8 times greater chance of landing up in hospital and dying.
That sounds correct. As I said, my maths is not on top form, but certainly, anecdotally from what the physicians are seeing in hospital, there are very few, if any, fully vaccinated patients in hospital. In fact, a couple of the ICU specialists across the country, from private and public ICUs, have in the last couple of weeks come out saying they have not had a fully vaccinated person in the ICU. And that's what happens with COVID, is that it becomes a pandemic of the unvaccinated. And those are the people who are going to get more ill.
So Sheri, before we turn over to Carl, who's going to pose all of the questions in the Q&A and some of the others that haven't been asked, let's talk about unvaccinated people. Do they pose a risk to those of us who are vaccinated? We've seen in America that companies like Facebook and Google say, if you're not vaccinated, you just don't come work for us. It's that simple. You pose a risk to those of us who are. Explain that to us and explain the dangers that unvaccinated people have to their colleagues at work and to go to clients, because many of our colleagues on the school actually go out to see clients.
So they do. So if you've got a population of people who are all vaccinated, so in a workspace or in a family home or whatever, the chances of any of those people getting COVID virus itself are that much smaller. The minute you introduce an unvaccinated person who can come in, it breaks down that kind of herd immunity within that little cluster. So I'm not talking about country herd immunity. I'm talking about within a small family grouping or a small work grouping. The unvaccinated people are much more likely to get ill, and therefore they're carrying a virus. So it makes the risk, we know that the risk of not getting COVID to somebody vaccinated is about maybe 65%. That's kind of globally looking at all vaccines. So if you, Howie, have been vaccinated, but your colleague hasn't, and they get COVID, you've got a 65% chance of not getting it, but you've still got a 35% chance of getting it. If you do get it, you've got maybe a 4 or 5% chance of getting it severely. But if the other person was vaccinated and didn't get it, you would have had a 0% chance of getting it and a 0% chance of getting sick. So you said work colleagues and clients, is it a risk to them? Yes, but it's a bigger risk probably to their elderly parents at home, even if their elderly parents are vaccinated. That's, or anybody vulnerable. And you don't know necessarily. You don't know which client is maybe pregnant, has an autoimmune disease, has something that didn't allow them to be vaccinated or didn't allow them to mount an immune response. So absolutely, unvaccinated people are a massive risk.
So, Carl, as you select what questions to pose to Sheri, and just a reminder to everyone, you can ask questions anonymously. Just use the Q&A button at the bottom. Carl, as you do, let's just touch on the issue of ivermectin. I know there's lots of dispute whether it works or doesn't work. Is ivermectin a replacement for a vaccine?
Absolutely not. Absolutely not. So whether or not ivermectin works still will hopefully come out by the time the big studies that are being done in the UK come out. As it stands now, the latest Cochrane review, which is the evidence-based review, is still going against it. I don't know, I'm personally not using it. I've seen many patients who've used it and not used it, and it to me hasn't seemed to make much difference. But nonetheless, ivermectin is probably relatively harmless, but it absolutely does not replace a vaccine. What puzzles me a lot in this pandemic is why the anti-vaxxers are also the pro-ivermectiners. I don't understand it. They've got nothing to do with each other. Everything that we do in COVID is like an extra layer of protection. So, wearing a mask is a layer of protection. Sanitizing your hands is a layer of protection. Having a vaccine is a layer of protection. Nothing is foolproof. You want to take ivermectin, it's maybe also a layer of protection if you choose to see it as such. It absolutely doesn't replace having a vaccine, which is our most effective strategy in terms of not getting severe illness.
Carl, you've got some interesting questions.
Yeah, I mean, Sheri, so How do you think our approach to the virus should change? Maybe question number one, post our first vaccine if we're getting Pfizer, and should our behavior change even further post the second shot, or should we be just doing things the same way we were doing them pre the vaccination?
So if you're in the middle of like the peak of a wave, which we're kind of just coming down from now in Gauteng, and if you're in a population where less than 10% of them are fully vaccinated, unfortunately, your behavior needs to still remain cautious. So you still need to wear a mask in a public setting, you still need to sanitize, and you still need to distance. If we get to a point where the viral load is low, so we don't have a 20% positivity rate of tests being positive, and there's a much lower viral load in the population and more people are vaccinated, then we can hopefully get to a point where you don't need to be wearing masks and you can be a little bit less cautious.
So maybe just a follow-on question from that. I mean, life beyond vaccines, not that there might not be life after vaccines based on boosters and all that type of stuff. But if you look at the behavioral changes in places like Israel, and now they're considering third booster shots, what does that look like, assuming we did get herd immunity via vaccines? Does life go back to normal based on your prior point, or are we always going to be on the lookout, even 1, 2, 3 years down the line beyond the States, for another booster, another shot?
So, normal seems like such a far way back, and I think it's still a little way in the future. And, I think that for a while still, we are going to be living still with caution. But I think that it's going to kind of become something that we live with without being in lockdown. So it's a slow process and a slow change, but the more people who've been exposed to the virus, either through having it or through vaccination, the safer we are as a population. And certainly going forward, masks I don't see as forever. They in certain conditions now you can also take off your masks if you're in a room where everybody is fully vaccinated and nobody is at risk. You can probably get away without wearing masks. But one person comes into that environment and that person is like the weak link in the chain because they're a potential problem.
Okay. And then, I mean, there's been lots and lots of asymptomatic cases, throughout from the start of COVID to today. How do you know if you are, you're eligible for a vaccine, you're happy to go and get a vaccine? Is there a reason that you potentially should test before getting that vaccine because, of this waiting period, or, just because you're nervous that you're asymptomatic, or must you just go ahead and get the vaccine done?
If you've been exposed to somebody, so you know that you're supposed to be in quarantine because you've got a contact, you definitely shouldn't go. You need to wait until 10 days. But if you're not aware of contacts and you're feeling absolutely fine, I would go and get a vaccine. There's no reason to test. If by chance, so I think what you're saying is like, if you've got maybe an asymptomatic infection and you have a vaccine, is it going to make you really ill? There's no evidence of that. So it's not. The problem that we have with that is that people may get symptoms a couple of days later and blame the symptoms on the vaccine, whereas actually they've been harboring COVID. But it's not actually dangerous to have a vaccine if you're asymptomatic and don't know.
Okay. And what happens when we get a new variant? What does life look like for maybe the vaccinated population?
At the moment, the vaccines have been quite good at evading all variants. And actually, it was quite interesting in South Africa because the beta variant that was dominant in December and January was actually better at evading vaccines than Delta variant. So with each variant, one's going to have to wait and see. It's really difficult to predict that. We will get new variants. We're hoping that the vaccines will still hold against it. But that's where having a booster dose may come in. And in the future, should a variant prove to be able to evade a vaccine, we are hopeful that the vaccines will be able to be tweaked so that they can include that variant as well as a booster. But that comes down to what I said about if you've had COVID, should you have a vaccine? We think that your immunity will be better against variants if you've had COVID and a vaccine, or if you've had both of your vaccine doses and you're fully vaccinated.
Okay. Just having a look.
Sheri, and Carl, can I just share one image with everyone? This is out of San Diego, and it's the hospitalizations. And it is comparing the number of vaccinated people in hospital to the number of unvaccinated people in hospital. And you can see that ratio, 521 to 13. That's quite telling. The other image that we can look at, which I'll share in a second, comes out of the United Kingdom, and that information also looks at deaths per million of vaccinated people now that they've been vaccinated versus previously. If I can just share that image with you. And this is what it looks like during the second wave when people were unvaccinated. There were 35.9 deaths per 10 million population, and that's gone down to 2.1 million because the population is so vaccinated.
And Howie, there are hundreds of figures and images like that online. It's difficult to have all the numbers and the statistics at my fingertips, but the truth is that the stats don't lie, and it's absolutely indisputable that vaccines prevent deaths, and it's indisputable that they prevent hospitalizations, and that's across all age groups.
Sheri, maybe one last question. Why are we seeing such a long tail in the third wave? What is causing that? Is it just the Delta variant being different? And then what does it look like looking forward to a fourth wave, assuming you've opened up vaccine centers, you should have, I don't know how many people vaccinated by the time that arrives. Will life be better, or do you believe that we're going to be in the same position as we are today?
No, I definitely think things will get better. The Delta virus, I think, is mostly responsible for that kind of slow tail that you're talking about. And if you look at the kind of graph coming down, it goes like that. At the moment, it doesn't kind of go down steeply. And I think that it's because Delta is so transmissible, and every person who gets infected can potentially infect 5 to 8 others, whereas with other variants, it was 3 to 4 other people. So I think it's partly that. I think it's partly behavior. KwaZulu-Natal's having quite a big spike now, a couple of weeks after the riots and looting where there were people on top of each other. A lot of it is behavioral. So, what worries me for the fourth wave, if you look at the timing, it's predicted in November, December. What really worries me this week is announcements of things like matric rage going ahead in Plett. I think that could really be a driving force for infections for the rest of the December holiday around the country, as it was last year. And I think that, things like that, gatherings like that, really need to be looked at carefully. I think we can do much more now than we could last year. I think that, people can get together with their families. They can see their elderly parents who this year, last time, they probably couldn't see because they're vaccinated. So I do think things are getting better. I think we're learning to live with the virus. And I think that the more people who have immunity, the better we will do.
So, Sheri, there's a question from someone, and I think it's a very important question, that says, what risk is there to society if I'm not vaccinated and I get COVID and I isolate? But it's really important that a big chunk of people who get COVID, about 60% have no symptoms at all. So they don't know they have it, and yet they spread it to other people. And even if they get COVID, they are most infectious in the 48 hours before they get their first symptoms. So they're spreading it to everyone without even knowing that they've got the disease.
So I think that's asked and answered. You've said exactly what I would have said. The risk is that you don't necessarily know that you've got it, number one, or number two, that before you've got symptoms is when you are mostly spreading it. And I must say, in practice, that's what we see. And I see it all the time. And I see people being so angry that they were infected by somebody that they had lunch with yesterday. and then the next day the person got symptoms and got a positive test. So you absolutely are at risk, even if you isolate, unless you're going to isolate and just not leave your home at all. Then you're at no risk to society. If you're out in society and unvaccinated, I do believe that you're a risk to others.
So, Sheri, maybe we end with an interesting question from Faik. And he says, if I had 2 minutes to convince someone else that they should get a vaccine, what should I say to them in those 2 minutes?
Sure, that's such a hard one.
Send him a recording, Howie.
I will give Faik a recording with pleasure, but sometimes family members don't want to watch an hour and 15 minutes. They want you to immediately, like, give me the bottom line, as we say in Yiddish, the unterste Schure.
So the bottom line really is that vaccines prevent severe illness and death, and that's what we need them to do. They can't prevent every infection and every mild infection, but as I said, the evidence is absolutely indisputable. They work and they're safe. So, it's really hard to do that in 2 minutes. I'm going to have to really challenge myself and try put out a 2-minute video. Because there's so much information that's got to go into that. What I would say to them is to really interrogate what they're listening to on social media that's putting them off, and to try and look at the reasons why they don't want a vaccine. For a lot of people, they're kind of pissed off with the fact that the government says you must vaccinate and therefore I'm not going to do it. So a lot of people are like anti-establishment almost and don't want to do something because they've been told to do it. And they want to do their own research, and they want to, thoroughly understand everything that goes into it. Well, I mean, do you know every single ingredient that's in a burger that you ate from McDonald's? You don't. COVID is the most absolutely scrutinized, overstudied illness by the lay population that we've ever seen. A lot of people who put stuff out there on social media, and some of them may be doctors, they are generally not doctors working on the front line of COVID, because if they are, and you see the devastation of somebody who is previously well and young and literally cannot breathe, and I'm sorry to get emotional, but it's literally like that. It's absolutely devastating to see somebody that you've known as well, go within a 10-day or 2-week period to being dependent on oxygen, and then CPAP, and then a ventilator, and then knowing that they're not going to make it. So, maybe you've got to go the emotional route. And often I can tell you that in my practice, people that have been very anti-vaccine, the minute somebody in their family has been really ill, everybody else has rushed out to get a vaccine. And sometimes it just takes somebody that you know and love getting sick to actually realize, and there have been lots of stories like that coming from hospital beds around the world, with people saying, can I get a vaccine now? And no, it's too late. You've got to have your vaccine way before the point where you're getting into hospital.
Amazing. Sheri, I think I can speak on behalf of everyone, and I just want to thank you for taking the time out of your, I know, very, very busy schedule. It was unbelievably insightful, and I think it cleared up a lot of the misinformation, at least in my mind, that I maybe was questioning, and I think for all our staff. And I think the credibility that you bring, having faced this head on, counts towards that. And we're very, very grateful that you gave us, literally an hour and 15 minutes of your busy schedule. And I think that the guys, all I can hope is that as a result of this, we're going to have a fully vaccinated workforce, and we contribute to getting back to maybe the way things kind of were.
So I hope I've helped, Carl. If somebody's got a specific question, you're welcome to email it to me, and I'll try and send you an accurate answer. But as I said, I just want to reiterate, I don't really understand the agenda of the kind of social media drive to anti-vaccinate. Really scrutinize what you're reading. Most of the credible sources are from doctors on the front line. And as I said, if you go back to what I said earlier, doctors were literally fighting each other in February to get to the front of the queue to get a vaccine. And that's my kind of best way of saying to you, just go do it. They're safe and they work.
But Sheri, I think one of the things is we all have an obligation as well, because in essence, we've got a highly educated company here. We've got lots of intelligent people, but there are a lot of people who don't have access to the sort of thing that we've done today. And hopefully we'll share this video with people and hopefully put it up on YouTube, if you don't mind, because this information is really, really important to people. But we've all got obligations, and they're people we deal with on a daily basis. I'm involved in a project to make sure that we vaccinate people in Area G of Johannesburg, which is South Lenasia, all the way through to Orange Farm, where there are only 5,400 vaccinated people out of over 900,000 at the moment. And we've got people who come into our homes, and domestic workers and gardeners and security guards and people who we see in the garage and people we see in our local shops. We need to get them all vaccinated, because that way we protect not only those people, but we protect ourselves as well. So each of us has an obligation to go and share this message and make sure that we get the entire country vaccinated, so we can return to a sense of normality as soon as possible. And I look forward to having to put on a collared shirt again and have a proper haircut and being respectable enough to go out in public.
Yeah, I agree. And so when you go and vaccinate, check with your, as how we did, check with your car guard, with your security guards, people who don't have access perhaps to technology to vaccinating. They really should be welcomed at most sites, and that includes people without a pass, without papers. They actually can go to sites and get vaccinated. So really just try get everybody out there.
And Sheri, let's just deal with costs, because there is no cost to any of this. Is that correct?
There isn't. If you're on a medical aid, your medical aid actually does get billed. But it's not a cost to you, so it doesn't come out of your savings account even. And if you're not on a medical aid, the cost is borne by government, so it's absolutely free.
So really no reason not to do.
No.
Okay, cool. Guys, Sheri, thank you so much for spending the time with us. Carl, thank you for allowing us to do all of this. And we hope everyone gets vaccinated, hopefully this weekend, and let's go on a better path from next week forward.
100%. Thanks,
Cool.
Sheri.
Cheers, everyone. Thanks for joining us. If you do have any questions, send them even anonymously to Carl, or Carl put up an anonymous questionnaire, and let's make sure that we can get everything answered.
Okay. Cheers.
Cool.
Bye.
Ciao. Bye.